Welcome to the Radiology Vault, an open repository for radiology educational content designed for learners and medical professionals. Presented by the Michigan Medicine Department of Radiology.
Here's how to do a G-tube injection. I have no disclosures. Before beginning, get AP and cross-table lateral abdominal radiographs to exclude pneumoperitoneum. If present, depending upon the circumstances, the patient may need to go directly to surgery without the G-tube injection. Under fluoroscopy, inject sterile water-soluble contrast, never barium. At Michigan Medicine, we use Isoview 250 or Omnipaque 240. We don't use gastrographin because it's hypertonic and may cause fluid shifts, particularly in small patients. Inject the tube in two orthogonal planes, usually supine and right decubitus. Save your images and fluoro clips. You should see contrast in the stomach with no extravasation, balloon in the body or antrum of the stomach not occluding the lumen, and contrast exiting the stomach into the duodenum. Here's an example of a normally placed G-tube. There's contrast and the retention balloon in the stomach. Sometimes inverting the image will allow you to see the contrast better. Here, contrast is exiting the stomach into the duodenum. In right decubitus, we can see contrast in the stomach and duodenum with no extravasation. The retention balloon is outlined by contrast in the stomach. This patient's G-tube fell out and was replaced. An overnight study was performed. Contrast appeared to be in the stomach. We see the retention balloon in the stomach, but we don't see contrast in the duodenum. So this contrast study was inadequate. An abdominal radiograph the next morning demonstrated contrast in the colon, so the G-tube was functioning properly. This patient had a G-tube placed a month ago, a liver transplant 12 days ago. The G-tube fell out and was replaced. We see contrast in the left upper quadrant, but on lateral, the balloon and tube are outside the stomach, and contrast is intraperitoneal. This patient's G-tube was functioning poorly. On injection, the retention balloon is outside the stomach in the tube tract. While still functioning, this G-tube will need to be repositioned. This injection was 2 days after G-tube replacement. We see irregular shaped contrast in the left upper quadrant superimposed on the gastric drainage tube. It's not clear where the retention balloon is located. On decubitus views, the gastric drainage tube appears in the stomach. The contrast collection extends more posterior than the expected location of the stomach. On follow-up abdominal radiographs, some contrast is present in the left upper quadrant and some in the bladder. On decubitus, contrast layers dependently. This is intraperitoneal contrast, which was partially absorbed and excreted by the kidneys into the bladder. The left upper quadrant contrast was probably in the lesser sac. This patient had granulation tissue and leaking around the G-tube, which was placed 3 months ago. On injection, we see the tube goes directly into the colon. Sometimes when placing the G-tube, it traverses the colon on its path to the stomach. Over time, the tube and retention balloon get retracted into the lumen of the colon, which will obviously have to be replaced. In summary, start G-tube injections with Scout AP and cross-table lateral radiographs. Use only water-soluble contrast and image injection in 2 orthogonal planes. Show contrast and retention balloon in the stomach, balloon not occluding the lumen. No extravasation, and contrast exiting the stomach into the duodenum. Thank you for listening.